Hello. So on this PowerPoint, I'm going to cover the lower leg and foot a little bit, a little more of the lower leg and the ankle. So just cover some basic anatomy first. Okay. So we got the tibia here, which is your shin bone that you usually like to find the edge of the bed in the middle of the night. Your fibula is the outer bone here. Your fibula weight bears about 10 to 15% of your weight during weight bearing activities. You can walk and run with a fractured fibula. It is very painful, but very possible, as most of your weight bearing is going to be just under tibia. Okay. Patella up here. Okay. Kneecap, femur up here. Everything is a factor. Down we get to the ankle. Okay, we have the talus, which sits up in here. Can I change my pointer a little bit? Let me see. So this talus sits underneath the tibia. Tibia. Okay, and it sits up nice and tall, hence talus. Okay, underneath the talus is, let me go to a different view. Okay, so here's your talus here. Okay, your tibia and fibula sit on top of this. Okay, underneath your talus sits your calcaneus. Okay, which is one of the hardest bones in your body. Okay, given this is a medial view. Okay. So in here we have your navicular, okay, which is kind of like the keystone piece of the arch. Okay, any damage to your navicular bone and your arch is affected in some way, usually resulting in like a flat foot injury. And then we have your cuneiforms, okay. Then we have your metatarsals, okay, and your phalanges, okay. Here is the lateral view, okay. So we're looking from the outside in. Okay, here's your calcaneus. Okay, here's your talus. Okay, here's your cuboid and all your cuneiforms. Okay, here's your metatarsals. Okay, this is your fifth metatarsal. Okay, so this one's very specific because the base of the fifth metatarsal, okay, sits right here. Okay, this part can be fractured off really easy, results in a lot of fractures down in the foot, just because there's not a lot of tissue that covers it. So weird steps, weird step-offs, anything that happens usually results in a fracture right here. Okay. So that's a very common area to fracture off. And you can easily just like, you feel it, oh, you get pain there, let's send you for an x-ray kind of thing. Muscle-wise, okay. So this one that's, for whatever reason, isn't labeled is your tibialis anterior. Okay, it sits in the front. So if you dorsiflex your foot, you can see that kind of bulge up on the top. Okay, on the outside, you have your peroneus longus and peroneus brevis. Okay, they kind of overlap one another, and they kind of help with a lot of the kind of stability of the foot. Okay. On the back, we have your gastrocnemius. Okay, which is your calf muscle. Okay, we have your medial and lateral heads of the gastroc. Okay, and then lower we have the soleus, which a lot of people consider like your low calf. Okay, that sits kind of underneath your Achilles. Okay, both your soleus and your gastrocnemius do plantar flexion. Okay, and they both attach to your Achilles tendon. All right. Your kind of extensor hallucis longus, that only goes to the big toe. Okay, and the extensor digitorum longus, those goes to all your little toes. Okay, ligament-wise, okay, so ligament-wise, I'm kind of like trying to be too mean, but the words get very confusing. Okay, so this is a lateral view, okay, of your ankle. Okay, so this one right here, we have your anterior talofibular ligament, okay, or often termed ATFL or TFL. Okay. So if you break down the word anterior, okay, anterior is in front, okay, talofibular, okay, talus and fibula, okay, so we have your talus here and fibula, so that tells you where it goes, okay, so it attaches to your talus and your fibula, and it's in front, okay, and it's a ligament, okay. Back here, we have our posterior talofibular ligament, okay, or PTFL, okay, obviously it's behind, okay, posterior, and then it goes from your talus to your fibula, okay. Down here, we have our calcaneofibular ligament, okay, or CFL. okay, goes your calcaneus to your fibula. Okay, your fibula is that outer bone out here. Okay, and then up here we have our anterior tibiofibular ligament and posterior tibiofibular ligaments. Okay, so if you break it down, your tibia to your fibula. Okay, tibia to fibula. People often get anterior tibiofibular ligament confused with the anterior tibia or talofibular ligament. Okay, so a lot of times we'll refer to the anterior and posterior tibiofibular ligaments as the anterior and posterior tib fibs. Okay, it's just a lot simpler. So that way, if you don't mumble like I do, easier for everyone to understand. Okay, and then anterior talofibular ligament is the ATFL. Okay, help break it down. Joints in the ankle. Okay, so there are 3. Okay, the first one is your talocrural joint. Okay, so the 1 degree of freedom or the movement here, okay, is going to be your dorsiflexion and plantar flexion. Okay, and this goes right here. So this is kind of just underneath your tibia and your fibula. Okay, and the top of the talus, the head of the talus. Okay, that is where this joint lies. Okay, this is where that plantar flexion and dorsiflexion occur. Okay, the 3 lateral ligaments, okay, are the anterior talofibular ligament, okay, ATFL, the posterior talofibular ligament, and the calcaneofibular ligament. Okay, so going back, we're talking about this one, and this one. Okay, these 3 kind of lower ones. The 4 ligaments medially, okay, are called the talocrural or the talocrural joint are called your deltoid ligaments. Okay, is your anterior tibio-talar. Okay, so your tibia to your talus. Okay, your tibiocalcaneal. Okay, so your tibia to your calcaneus. Your posterior tibio-talar, and your tibio-navicular. So your tibia to your navicular, which is that kind of like keystone piece of your arch. Okay, a lot of time these are all grouped together because they're very, very close knit. And the deltoid ligament, which is medially, is very, very strong. Every medial ankle sprain that I've seen, I've referred to a physician for an x-ray because usually they result in some kind of avulsion fracture. Just because these ligaments are so strong in here that usually it's going to pull the bony attachment of it off. Okay, that's how strong they are. Okay. Doesn't happen too often with the lateral ligaments, okay? Only the medial ones. Because medial ankle sprains are very, very rare. And all the hundreds of ankle sprains I've seen, I've only seen 2 medial ankle sprains. And both were pretty much season endings because of the amount of pain and instability that results in them. Okay, the next one is your syndesmosis joint. Okay. So this is pretty much the joint right in here, kind of between your tibia and your fibula. Okay, it goes up a little bit farther, but the bigger interaction is going to be right in here. Okay, and it's pretty deep. Okay, so the 3 ligaments in here, okay, are the crural interosseous ligament. Okay, which is here's your interosseous ligament right here. They'll also call it the interosseous membrane. Okay, and this goes all the way up to almost your knee. Okay, all the way between your tibia and your fibula. Okay, just directly in between. The other one is going to be your anterior and posterior tibiofibular ligaments, okay, or your anterior and posterior tib fibs. Okay, there's not a lot of widening that occurs here. Okay, usually results anything more than a few millimeters results in an excruciating amount of pain because it's a very, very stable joint up in here. The next one is going to be the subtalar joint. Okay, so this is the articulation between the talus and the calcaneus. Okay, it's a little bit lower. Okay, this is where your inversion and eversion occur. Okay, so if I go back a little bit, okay, that is going to be between your calcaneus and your talus. So right in here. Okay, so this is all that inversion, eversion that occurs. Palpations, obviously we're not doing any palpations for this as online class right now, but you can palpate the ATFL. Okay, the PTFL is a little more difficult, yeah, like probing a little bit harder to find it. You can't really feel it exactly. And the calcaneal ligament you can also palpate as well. The medial, the deltoid ligaments, which are medially, okay, they're just kind of like grouped together, so you can't really identify anything, and they're so kind of overlapping one another. You can most part palpate them for pain, but you can't identify one versus the other. And there's no real ligament test that identifies one versus the other. Other ligaments to consider, okay, interosseous membrane, okay, that's between the tib and fibula. You can't palpate that one. The anterior and posterior tib fibs, okay, you can palpate those to an extent. Some of them are kind of encased within the kind of capsule of the ankle joint, so it's kind of hard to identify. And last one is the spring ligament, which is the calcaneonavicular. Okay, that is one of the. Go back. Okay. Go. Okay, so your navicular bone is right in here. Okay, here's your calcaneus. So your calcaneonavicular goes right in here. Okay, and this is called a spring ligament because if you tear it, you lost your spring. Okay, and you're pretty much immediately flat foot as a result. Okay, you can palpate it to an extent, especially if it's sprained or torn. Bony landmarks, okay, fibular head, tibial shaft. Some of these we'll cover if we have a lab by chance, but usually not so much. The fifth metatarsal, which is the styloid tuberosity, I talked about that previously, the kind of outer metatarsal of the foot that kind of fractures off pretty easy. Okay. Let me see. I'm going to skip over this for right now. Here's all those ligaments again. Okay. Some foot deformities that can occur. Okay, so we have pes cavus and pes planus. Okay, so pes cavus is also called high arches, okay, or rigid foot. And pes planus is flat foot or more mobile foot. Okay, so not saying that one is better than the other or one's worse than the other. Okay, a lot of these deformities are mainly how people are born, especially the pes cavus. Pes planus can be a result of just kind of weakness of the whole foot and kind of just over years and years and years of either poor arch support, poor gait or walking patterns, or a number of different things. Okay, but some people are just born flat foot. Okay, other things to keep in mind. Okay, so if you have pes cavus, okay, your arch is higher. Okay, so a lot of time you'll have this external tibial rotation that happens. Okay. Also a little bit of kind of this outer rotation of the foot, okay? And then you're going to have this kind of medial rotation as a result. You always have this like pigeon toe walk. So they're walking very much like this, okay, as a result. Okay. The pes planus, okay, is the opposite. So this arch is going to drop, okay? You're going to have a internal rotation of the tibia, okay? And you're going to have your feet kind of swing out. You're going to have almost this duck foot walk, okay? Pes planus is more common as a result. I've seen a few cases where it's very, very extreme to where they're all the medial structures like the malleolus right here, which is kind of like the ankle bone that sticks out, actually hits the ground. That's how far that rotation occurs. Most of the time for both these individuals, whoever has it, there's not really any symptoms. That's just kind of what you may experience. But things may kind of predispose you to other areas because, let's say if you have more of a external or internal rotation of your tibia, that can affect movement gaits, can affect other issues such as meniscus kind of wearing, prone to ACL tears. Also predispose you a little bit more to more like plantar fasciitis and other issues. I'm skipping all these special tests right now just because I am taking them out of this class. It's just a little too advanced for some. I'll talk a little bit about the bump test. Okay, this is used for to assess fractures as well as a few other ligament tests. So for the bump test, you're going to have the patient kind of sitting or laying down, okay, foot kind of hanging off. I'm going to hold their foot with one hand in neutral position. Other hand, I'm just going to bump their heel. Okay, that's it. If pain is felt, then I'm going to send them for a possible fracture somewhere in their lower leg, okay, as a result. If I already know that there's a fracture, I'm not going to do it because you're just causing more pain and agony on the individual, and that's pointless. But that can help with that. Okay. Also, you said assess some other high ankle sprain issues, but we're not going to worry too much about that right now. All right. So question for you. So when I get out of bed in the morning and take my first step, I have a really sharp pain in the bottom of my foot. After I walk around for a while, it gets a little better, but it feels like something is tearing. It hurts just in front of my heel. What am I? So this is a very, very classic kind of like sign symptom for someone to experience when they come up for plantar fasciitis. Okay. So plantar fasciitis is just inflammation, hence the itis is inflammation of your plantar fascia. Your plantar fascia is just this really thick connective tissue on the bottom of the foot. Actually, your Achilles comes down and wraps around your calcaneus and becomes your plantar fascia. Okay, which is this very thick connective tissue that really helps support and give you a little bit of that spring when you walk and run and jump and everything. Most of the time, the primary area where you have all the pain is just in front of your heel. Okay. Usually, this is all brought on by changing in training, changing in maybe like amount of walking, overtraining, changing footwear, heels. There's a big component of this. Improper fit shoes. Shoes you're maybe not used to. Excuse me. A lot of things can affect and give you plantar fasciitis. It's very much a pain in the butt. Don't be wrong. You can also have a result of kind of like heel spurs, which is like this growth of bone that happens. It kind of pokes down, so it just kind of irritates your plantar fascia, which is sometimes pretty common in some individuals. The treatment is, there's a number of things. I cover that in the next slide. Oh yeah, so heel pain, okay, obviously when standing on top of toes, tenderness, swelling, can be numbness sometimes. Pain is worse in the morning, and that's only because when you're sleeping at night, healing is occurring, okay? But not enough healing has occurred to maintain your weight when you first step on it. So all that healing that occurred at night, when you first stand up, you're pretty much ripping away all that little bit of healing that's occurred. Okay, that's why when you first step out of bed, it's usually very, very painful. Okay, that's a very, very classic sign. 9.9 times out of 10, okay, I literally will say the exact same thing to them. Like, hey, when your first step out of bed, does it hurt like a lot? And then it gets a little bit better. And you're like, yeah, it is it. So classic. Okay, so treatment, okay, ice, okay, NSAIDs, non-steroidal anti-inflammatory drugs. Okay, so that's like Aleve, ibuprofen, or NSAIDs. Okay. They don't do like a ton for like the pain, but they do help with any inflammation, which you want to keep under control. Ice is mainly for pain management for the most part. Some kind of shock absorbing heel pads can help. Okay. Arch tape can help a little bit. Okay. Heel cords stretching, that's more of your gastroc and soleus stretching. Okay, because that attaches to your Achilles, and your Achilles comes in around your calcaneus and becomes your plantar fascia. Strengthening the intrinsic and extrinsic muscles of the foot. Okay, so intrinsic is all the muscle that is within the foot, and the extrinsic muscles are the muscles that is outside of the foot area, but still corrects it, or still plays a factor. So pretty much any of the muscles we talked previously, like your gastroc, your soleus, your why am I drawing a blank right now? All of these up here, okay? So your perennials, okay, your external digitorum longus and external hallucis longus, and also your flexor digitorum longus and flexor hallucis longus. All those are extrinsic. Okay, all the intrinsic ones are the ones, all the muscles are actually within the foot. Okay, and then correct mechanics. Okay, whatever that is. That could be just give them a little break. That could be footwear, number of different things. It has to be very tailored to the individual. Management, okay, price, okay, protection, rest, ice, compression, elevation, okay, if need be. Good arch shape can help a little bit. I said it, I think all these already. X-ray to see if there's any kind of bone growth. Sometimes they will operate on that to help with it. Next is ankle sprains. Okay, very, very common. The number one pretty much injury in all of sports, okay, is an ankle sprain. Okay, so mechanism is indirect trauma forcing the ankle into an inversion, stretching the lateral ligaments. Okay, so signs and symptoms. Okay, point tender over the lateral ligaments. Okay, swelling, hemorrhages, bleeding. Okay, which can occur. Possible deformity, especially with third-degree injuries. Okay, ecchymosis. Ecchymosis is the discoloration of the skin, usually resulting from some kind of bruising or bleeding internally underneath the skin. Instability with second and third-degree injuries. Inflammation, obviously. Pain on active and resistive movements. Pain on passive stretch. Loss of normal ankle function and tenderness. Okay. Special tests, don't really worry too much about those just because I kind of took those out. All right. Ankle sprain versus high ankle sprain. Okay, high ankle sprain is also called a syndesmotic sprain. Okay, so you guys, I'm asking, what do you think the difference is? Okay. Everyone's heard of high ankle sprain and a normal ankle sprain. Okay, so I'm a little too ahead of myself. Let me go back a little bit. Okay, so normal ankle sprain affects the anterior, posterior, and anterior and posterior talofibular ligaments. Okay, and the CFL, the calcaneofibular ligament. Okay, so these are three ligaments that can be affected during a regular ankle sprain. Okay, most of the time it's going to be the ATFL and the CFL. Okay. Are the main ones. The main one is going to be the anterior talofibular ligament. Okay, 10 times out of 10, that one's associated. Okay, followed by the calcaneofibular ligament. Okay, and then the posterior talofibular ligament is not really sprained too often just because it's a lot bigger. Okay, so these three are associated with normal ankle sprains. High ankle sprains are more the anterior and posterior tibiofibular ligaments and the interosseous membrane or ligament that we talked about previously. Okay, so those are important because the anterior and posterior tib fibs, okay, and interosseous membrane, their main job is to just keep the stability between the tibia and fibula. Okay, if there's widening of that tibia and fibula, okay, results in the sprain. Usually, a widening of more than 7% of that ligament's length results in an injury, which is not very long if your anterior tib fib is, let's say it's 10 millimeters, okay, long, however long it is. I don't know exactly how long it is, okay, but a widening of 7%, okay, that's just under 1 millimeter, okay, results in an injury, okay, so it's very, very stable. So result in that, then every time that you weight bear or do a movement that results in some kind of closed pack position of the ankle is going to widen that, okay, results in a lot of pain. That's why with high ankle sprains, it's very, very common for like basketball athletes, for volleyball, for any of the real jumping sports, okay, because anytime they come down, they're going to widen this kind of joint, that syndesmotic joint, resulting in a lot of pain, okay. You're not going to have too many landing, or it's not going to be as bad with the regular ankle sprain stuff because you can stabilize it a little bit easier than the higher ankle sprains. Okay, higher ankle sprains also require more rest time usually as a result. Okay, it's different degrees. Okay, and this is mainly referring to the normal ankle sprains. Okay, so first degree, which is most, like 99% of all the ankle sprains, okay? Pain and swelling on the anterior lateral aspect of the lateral malleolus, okay? Point tender over the anterior talofibular ligament, okay? They don't really have any laxity. Okay, so it hurts on the lateral ankle. Okay, right where the ATFL is. So if you're looking at your ankle, it's a big bone that sticks out on the lateral side. Okay, that's your malleolus. Okay, so a lot of the pain's gonna be just in front of that. Okay, that little kind of like divot and void that's right there. Okay, and that's where your ATFL is located. Okay, a second degree, okay, sprain is tearing or popping sensation felt on the lateral aspect, pain and swelling on the anterior lateral and inferior aspect of the lateral malleolus, painful palpation over the ATFL and CFL. Okay, may also be tender over the PTFL, deltoid ligament, and anterior capsule. Okay, and they do have some pain and laxity, a little bit. Okay, so we're talking about the malleolus. Okay, that bone again. Okay, they're gonna have pain in front and underneath. Okay, for the most part. Okay, they can have pain behind, which can affect the posterior talofibular ligament. Okay, and then they could have pain on the deltoid ligament, which is inside. Okay, a third degree, okay, is tearing or popping sensation felt on the lateral aspect with diffuse swelling over entire lateral aspect, with or without anterior swelling, can be very painful or absent of pain. Positive on the test for laxity and pain. Okay, when it says pain is absent, that means you probably tore some of the nerves there, so it doesn't transmit any pain. So grade 3 is a complete tearing of usually one or more ligaments. So you can have a deformity. Okay, I say deformity is it's gonna look nasty. Okay, in some way. Okay, you don't have the skin doesn't have to be torn during this. The few grade 3s that I've seen, the skin was not torn in any way. But her ankle, instead of being normal, it was completely rolled underneath her foot. Okay. Okay, and then we're talking a little bit about some evidence-based practice stuff. Okay, and the SORT, which is the Strength of Recommendation Taxonomy. Okay, so there's 3 grades, okay, A, B, and C. Okay, so A is recommendation based on consistent and good quality experimental evidence. Okay, B is recommendation based on inconsistent or limited quality experimental evidence. And C is recommendation based on consensus, usual practice, opinion, disease-oriented evidence, case series or studies of diagnosis, treatment, prevention, or screening, or other kind of quasi-experimental research. Okay, so obviously A is the best. Okay, C is not the best, but C is not bad. Just know that. Most of the stuff I'll talk about is going to be based on C, just because some of it we don't have the research done yet, or we don't have enough research studies on it. Okay, because to get the A, you need a lot of different studies on that specific thing, whatever it's talking about. And they usually look at one item versus another. Okay, but you can't get to A without a lot of C's. So just know that. That even though a lot of stuff we're going to talk about is going to be C based, okay, doesn't mean it's bad. Okay, it just means that, like, let's say usual practice. Okay, usual practice is usually we do it because it works. Okay, some stuff does not work, and then we do enough research on it to say, all right, so we need to stop doing this because this is either not working well, harmful, bad outcomes, whatever it is. Okay. All right, so the first one is to talk about diagnosis, and some will skip over versus others. Okay. So I also have the evidence-based practice, the grade in here on whatever I'm talking about. Okay, so this is grade C. Okay, so you should also always take a patient sample history. Okay, HX is history. Okay, make sure you get the symptoms, allergies, medications, pertinent past history, last oral intake, and events leading up. Okay, this is sample. Okay, SAMPLE. Okay, there's a little acronym for you. Can help you kind of size up everything. Okay, once you get everything, okay, you have your, well, let me go back a little bit. Okay, so symptoms, okay, is everything that they can describe to you. Okay, allergies, okay, are they allergic to anything? Okay, medications on any meds, they can always play a factor. As medication, let's say they're on a blood thinner. Well, they're going to bleed more. Okay, for example. Pertinent past history. Okay, have they have any other ankle sprains previously? Okay. Last oral intake. Okay. Very, very important, especially if they have to go into surgery as a result of whatever injury it is. And events that led up to the incident. Okay, for example, I tripped over this little curb on the way here. I fell because I just had my eyes dilated, kind of a thing. Next is going to be observation. Okay, so observation is going to be what you're observing of them, what's happening. So, all right, I observe some discoloration of the skin, which is called ecchymosis. I observed them limping in when they first came in for me to check on their injury, and anything similar to that. Next would be palpations, which you guys shouldn't worry about right now. We got to palpate to see any kind of deformities, rigidness, anything like that. This is not assess severity. Okay, this is kind of just helping you kind of size up everything that's happening. Okay, because just doing the sample history, which is so important that I can't emphasize it enough. Because you're going to find, all right, maybe you're going to find everything that you expected, but a lot of time you're going to find things that you did not expect. Okay, and given this is more on the ankle-related stuff, but let's say it's the gen med stuff, you can find other items that is even more important than what they came in for. Okay, so it's super important to get a really, really good history. And if you find something that kind of catches your attention, dive deeper down that path. All right, so next one, another grade C, okay. Assessment of active range of motion, passive range of motion, and resistive range of motion can help identify pathology related to ligaments, muscles, tendons, and nerves. Okay. Also, special tests, anterior drawer and tailor tilt, have better accuracy when performed before infusion. So the assessment of all these range of motions can help identify if it's more ligaments, muscle, and so forth. Okay, that's all that means. Even though we're not doing too much of range of motion items in here. And then this next one for some of these tests. So these are more accurate before that swelling within the joint occurs. Okay, you're going to get a better readout of that pretty much as soon as possible, is what it says. Because if you can do some of these tests within 10 minutes of the injury occurring, you're going to have really, really good reads on what it is. Because once the swelling occurs, that swelling is a way of self-splinting. Okay, next one was grade B. Okay, so some of the special tests, anterior drawer and tailor tilt, more accurate 5 days post-injury than 2 days. And that's just a result of swelling. Usually after about 5 days, the swelling kind of goes down a little bit. That way you can get a better reading. Okay, better than 2 days. But obviously, if you can get it done immediately, you're going to have a better result than 2 days. Okay, another grade C. Special test for high ankle sprains to assess anterior, inferior tibiofibular ligaments. Okay, the squeeze cotton, external rotation, and tibular translation tests. Don't worry about these tests right now. Okay, it'll be later on in your career. We'll get some of these. Next one's grade A. All right, grade A. Okay, so the Ottawa, or however you want to say that, ankle rules. It's a valid tool to determine need for X-rays and acute ankle sprains. And I will talk about the Ottawa ankle rules, or ORs, here in a little bit. Next one's grade B. So a stress X-ray, okay, is unreliable to determine acute ligamentous injuries. Okay, so stress X-ray is pretty much them. Usually some kind of stress is applied to that joint. Okay, for example, like weight bearing, when they take the X-ray to identify displacement in the bone. And that is not reliable. Just know that. Okay, next one's grade B. MRI is reliable tool to detect tears to the ATFL and CFL after acute injury. Okay. All right, the Ottawa ankle rules, or the ORs. Okay, developed to reduce the unnecessary X-rays on ankle sprains. Okay, Because ankle sprains hurt. Don't get me wrong. They hurt. Even the mild ones. A grade 1 sprain can still hurt like hell. Okay. This was made because there's around 28,000 ankle sprains a day in the nation. 80 to 95% of them have x-rays ordered. Okay. Okay, and that's just under 27,000 x-rays a day. Okay, that's really unneeded. Because most of them are negative. Okay. Only 15% have a fracture, okay, or break. Okay, that's a little over 4,000 of them. Okay. Another big reason for the x-rays is usually insurance reasons. In order to get like an MRI of that, you usually require an x-ray. Okay. So there's orders for the foot and orders for the ankle. Okay, for the ankle is pain present on the malleolar zone, and the patient presents as bone tenderness along the distal 6 centimeters of the posterior edge of the medial and lateral malleolus. Okay. Okay, so the posterior edge of the malleolus, okay, is going to be down here. Okay. Tenderness at the tip of the medial and lateral malleolus. Okay, so that little tip right here. Inability to bear weight and walk 4 steps immediately after injury or in the ER. Okay. Tenderness at middle third of malleolus. Okay. Okay, so the middle third of malleolus right here. Okay. And then for the foot, okay, pain present in the midfoot zone. Okay, so up in here. Tenderness at navicular bone or base of the 5th metatarsal. Okay. I talked about the base of the 5th metatarsal here. Okay, the stylotuberosity. Okay, and then the navicular bone is here. Okay, it's mainly medially. Okay, inability to weight bear and walk 4 steps. Okay, so any of that requires an x-ray. This can help rule out a lot of different things. Okay, next we're going to talk about treatment and rehab. Okay, so grade C, cryotherapy, aka ice. Compression, elevation, and electrical stimulation has been used to treat pain, swelling, and reduce secondary injury. Okay, so ice with compression, okay, and elevation, and electrical stimulation, which is E-stem refer to it. They put the little pads on and they kind of shock you and you feel weird sensations. Is really good to treat and reduce secondary injury. Grade A, NSAIDs, non-steroidal anti-inflammatory drugs, oral or topical. Reduce pain, swelling, and improve short-term function after sprains. Another grade A. Functional rehab is more effective than immobilization in managing grade 1 and grade 2 sprains. Super important. Okay? And it's functional rehab. Okay? Grade B. Grade 3 sprain should be immobilized for a minimum 10 days with a rigid stirrup brace or below knee cast, followed by rehab. Okay? If you suspect a grade 3 sprain, that's automatically you're referring them to a physician, okay, for the eval. Okay, because if it's a grade 3, okay, there's a complete tearing. Also, what else is affected as a result of that tearing? Okay, you don't know. All right, grade C, thermotherapy should be avoided. Okay, thermotherapy is heat therapy, okay, or any heat. Should be avoided during acute and subacute phases of injury due to lack of evidence and potential to exacerbate injury. Okay. Heat will bring more blood to the area is not always what you need, because with blood comes increased swelling and effusion, which can just increase the recovery rate. Grade B, rehabilitation should include range of motion, flexibility, and strengthening of the surrounding musculature. Absolutely. Grade A, balance training should be incorporated throughout the rehab to reduce re-injury. Super important. Balance is super important. Okay, and really easy to do. All right, return to play, prevention, and special considerations. All right, grade C, patient's perception of functional and age should include in the return to play. So these are just some questionnaires and instability tools, okay, that can help out. And this is just like how they're perceiving their care. That's all it is. Grade B, functional performance testing should be made a component of return to play. All tests should be measured 80% versus uninjured limb. Okay, so whatever test you're doing, hop tests, jumping, shuttle runs, cone drills, whatever it is, should be at least 80% compared to their uninjured. Another grade B, wear prophylactic ankle support for games and practice, should be composed of lace-up and semi-rigid as well as traditional ankle taping. Okay, so you're getting the ankle brace with an ankle tape. Okay, it's a lot of stuff, but you need usually a lot of that stuff. And usually the little difference between the prophylactic ankle support or the why am I drawing blank right here? Just your ankle brace and the ankle taping. So the ankle brace lasts longer than taping, okay, but is not very customized to the fit, okay, to where the ankle taping is very customized to the fit, but does not last very long. Okay, so that's why you should probably use both. Grade A, injury prevention programs lasting minimum 3 months, focusing on balance and neuromuscular control. Okay, balance is huge. Okay, and then neuromuscular control is how your nerves and muscles, or how efficient they are in controlling your foot and ankle. Okay. Grade C, leg length should be addressed. Lower leg, everters, inverters, dorsiflexors, and plantar flexors. Okay, and for the hip is extenders and abductors. Sorry, leg strength. I said leg length. Leg strength should be addressed. All those are very, very important. Okay. Grade C, assess improved dorsiflexion to enhance arthrochromatic and osteokinesmatic motions. Okay. So what it means is you need to look at more than just the ankle to help fix the problem. Grade C, syndesmotic high ankle sprains should be evaluated, including palpation, clinical testing, functional evaluation, radiographs, and MRI if indicated. Okay, so that's more the referral to the doctor to do all that. Another grade C, syndesmotic ankle sprains should be treated more conservatively than lateral ankle sprains. Acute management requires immobilization, non-weight bearing, walking boot, casting, or bracing to allow healing. And then another grade C, surgical considerations for syndesmotic sprains that demonstrate widening of the ankle greater than 2 millimeters on standard or stress x-rays. Okay, so for that high ankle sprain, a widening of more than 2 millimeters, which is nothing if you think about it, can result in surgery. Now all I'm going to do is put like a screw all the way between your medial and lateral malleolus, just right through your ankle. You kind of keep that together. Best outcomes for grade 1 and grade 2 ankle sprains. Okay, so elastic wrap plus air strip. Okay, so this is an air strip right here. Okay, there's kind of like this. The white area is like a hard plastic, and then the kind of like neon green, whatever it is this gel pad. The gel pad goes from the bottom all the way up to the top. Recovery is 5 days versus 12 days in elastic wrap alone. Okay, so the air strip is a big component of this. Air strip is not to be worn during athletic movements or anything like that. It's more just like your everyday walking around, getting to class, kind of a thing. Okay. RICE. Okay, so rest, ice compression, elevation plus therapeutic exercise. Okay. Recovery is faster than rest alone. High volt pulse current. Okay, that's a setting on the TENS unit, or not TENS, the unit like right here. You can see, right behind me. Okay, electrostimulating unit. Okay, that's a setting on there. Plus RICE is very effective. NSAIDs are really good. Exercises for all lower leg muscular surrounding ankle joint. Okay, special attention to the concentric and eccentric functions of the movement. Balance training. Okay, obviously. Restore range of motion, specifically dorsiflexion. Okay, joint mobs to restore, improve range of motion. Okay, I didn't talk about joint mobs, so don't worry about those right now, but they are very, very important. All right, shin splints. All right, so what are shin splints? Okay, when do they happen? What do you do for them? Okay, So just like think back if you've ever had shin splints, if you had chronic shin splints, maybe you've not, but you have all your friends complain about them. Okay, so what's your idea of what a shin splint is? Excuse me. Okay, for one, shin splint is just pain in the shin. That's all it is. Okay. When do they happen? Usually before, during, after activity. Okay, and then what do you do for them? People often they ice them, they tape them. Are the really, really common things. They rest them, they run through them, whatever it is. Okay. Okay, so shin splints is an umbrella term, okay, for just pain in your shin, okay? The things that it could be, tibialis anterior tendonitis, tibialis posterior tendonitis, periosteoitis, which is inflammation of the outer layer of the bones, tibial stress fracture, okay? Fibular stress fracture, reoccurring chronic anterior compartment syndrome, okay, really bad. Inflammation of the inflammation of the interosseous membrane. A number of different things can cause shin splints. I think the most common one is going to be the tibialis posterior tendonitis. Okay, so the tibialis posterior is a muscle that has wrist just posterior to your tibia. That runs all the way down and helps support your arch a little bit. Okay, that's just what I believe is the most common form of shin splints, but it doesn't fit everyone. Okay, so a good eval is very, very important to this to assess what it actually is. So really assess what is wrong first, and then fix that, because everyone's unique. Okay, whatever it is, taping does not do anything. Okay, just know that. If anything, it makes it worse. Okay, I refuse to tape. I don't care who you are. I'm not going to tape it. For one, it's a waste of tape. For something, it's just going to make it worse. Because usually what it is that inflammation, okay? So inflammation usually results in some kind of swelling, okay? And now we're going to tape it down and more restrict it, okay? Which is going to cause worse pain, okay? So taping just makes it worse, okay? And when I say shin splints is an umbrella term, it's because no one knows and no one can classify what it exactly is, okay? Whatever the organization that you're working for or that you belong to, no one can identify what exactly shin splints is, okay? Because it's very much an umbrella term, okay? Possible mechanisms that can affect shin splints: poor footwear, new or old shoes, poor foot mechanics, pes planus or pes cavus, okay? Flat foot, high arch, muscle imbalances, changes in workout, increases in intensity and duration, running mechanics, I think I mentioned that a little bit earlier, muscle weakness, poor arch supports, tendinitis of muscles. Solutions: find the source. Very, very important. Okay, what's the cause of all this? Fix mechanics, the problem. Isom is needed. A lot of stretching. Okay, maybe slow down on everything. Okay, cross train. Okay, and cross train, if you had never heard that expression before, is do something that doesn't hurt it. That's very almost similar to what your main activity is. For example, shin splints is very common in runners. Okay, so for long distance runners, and it hurts to run. All right, so instead of doing all the runs, okay, maybe let's put you in the pool, okay, and do some like cardio in the pool, and then slowly build them back up. All right, lower leg fractures, okay. So I'm not going to show the video here just because you can watch a number of different videos. I might post some in the modules if I find some good ones. This one's getting it doesn't have the best quality, okay. So I believe this is Kevin Ware, whatever, like 10 years ago, when he came down and landed and fractured his tib and fib. Okay, so that's actually the tibia that you're seeing right there. Okay, so what you're going to do immediately is obviously call 911. In this case, there is paramedics on site. Okay, somewhere in the stands, behind the scenes, whatever it is. Okay, ABCs. Okay, air, breathing, circulation. Okay. Because no matter how nasty, he could lose his leg, okay, is he alive? Okay, that's the one thing you need to maintain first. Okay, and then pulses, okay. So given the semester right now, maybe we have or have not covered pulses depending on COVID reasons and so forth. Check the pulses usually distal to the injury, okay, to make sure they still have blood flow. If they don't have blood flow, then they can possibly lose their limb, okay? And that's a limb-threatening injury, and that is more important to communicate that towards EMS because that usually makes things go a little bit faster in terms of the ride and so forth, because they have that kind of golden hour before they're going to lose that limb, okay? In terms of this, you want to pack it with gauze, okay, kind of controlling bleeding, okay, and immobilize it, okay? But you immobilize it in the area where it's found, okay? The best thing to use for a compound fracture, okay, like this, compound is just because the skin's broken, is a vacuum splint, which, depending on where we're at this class, I think I cover a little bit of it in splinting, because the vacuum splint can split any joint in the position found. Okay, so it's very, very important. And then you got to transport them to whatever the local hospital. Usually we just rely on EMS, like, hey, where are you going to take them? And they'll kind of dictate depending on the circumstance. For example, if we're here in Fresno, they might take them to the CRMC, which has a trauma center, level 1 trauma center, for maybe something that's bad. Like they'll kind of play it on whatever they think's the best. Yeah, and you just trust them on that usually. All right, so that is the intro lower leg.